Hello, everyone. Thank you for joining me today. I've got a very special guest for you, and we're going to dive into the topic of pediatric growth and development, how we can prevent orthodontics in kids, how we encourage the growth of the dental arch in children, and how crooked teeth may be the symptom of other issues in kids. Dr. Sherri Sami is a dual trained pediatric dentist and orthodontist, and she's one of the most specialized people in the world to be talking about what I feel is one of the most important topics in the world. She's based in California. If you're watching this broadcast, please say hello and tell us where you're joining from. We're going to be asking some questions, and Dr. Sami and I are going to dive deep into the topics of pediatric orthodontics. Dr. Sami, thank you so much for joining me today.
Thank you so much for having me. It's such a pleasure to finally meet you, even over the internet. But I've been a big fan of finally somebody wrote all of these things in a book that it's readily and available for parents, because I think most of the books that they were written, it was in such complex language that people couldn't decipher. But I loved when I saw your book of dental diet on the Borders and Barnes and Noble's shelves. It just made my heart sing, and it so resonate with my philosophy.
Yeah, absolutely. And when I found your work, I was just so pleased that someone of your speciality was talking about these issues, because I think there are a lot of parents out there that they feel a bit hopeless and maybe a little in the dark as to this very difficult problem as to the growth and development of the dental arch. Right. Take us back a little bit into your story. You first trained as a pediatric dentist. What was your driving point in that? Why do you feel you moved into that area of dentistry?
Well, I've always loved children. I started actually at 14. I got a disease called brucellosis, which is a bacterial infection that affects one of your bones. And for about 6 months, there was a lot of cortisone shots, and a lot of painkillers, and a lot just kind of shooting in the dark. And I was completely bedridden in the hospital for 6 months. It was a very interesting and challenging time of my life, but it was a time that I decided that I want to work with children, and I want to make sure that I become the kind of a doctor that sees them as a whole in all aspects of physical, emotional, mental, and later on spiritual. So once I was kind of going back and forth between becoming a pediatrician versus, pediatric dentist, started working with some cleft palate patients at Columbia. And I decided I want to become a pediatric dentist and orthodontist. So initially I thought I'm just going to do them separately, but by some kind of grace, I was really grateful that I got accepted to the only program, pedo ortho program in the whole entire United States at UCLA at the time. And I did pedo ortho together. And then right afterward, I became a professor at UCLA. And then again, by, how life and calling and love and God, whatever you want to call it, it kind of leads you. There was a program called Children Health Advocacy Training at UCLA that was supposed to be run by someone else, and it kind of fell on my lap. The reason that was such a turning point, it was because I was working with pediatricians, cardiologists. I was working with pediatric medical residents and pediatric dental residents. At the same time, I was teaching at the craniofacial clinic, and I started looking at children as a whole and seeing, wow, there's just so much, that happens in the mouth that can be expressed in the gut, and so much that in the gut that can be expressed in the mouth. So much happens in the cranium that can be expressed in the neck, torticollis, and, lordosis, kyphosis, things in the back. But yet nobody really, like these practitioners, pediatricians, they don't know anything about the mouth, and the pediatric dentists, they don't even look at the rest of the body. So how wonderful it would be that we can bring all of these things together and we start looking. And then somehow my journey took me through food as medicine, which is something that as doctors, we never get trained in. We just look at the disease and we look at symptoms. We never really look at the cause of these symptoms, and we never really look at nutrition as part of these. So it kind of like almost gracefully just kept, leading me to the next step and next step. And the more that I learn and still learning, the more that I find out how the entire human, it's just one thing. And the way that we separate and segregate and create all these specialties, and yet these specialties, they never really talk to each other, and they all treat differently and separately, as if the pieces of the person was in separate ways. It doesn't necessarily serve the person, and it definitely doesn't serve our children. So I decided to kind of take a leap of faith. And about 15 years ago, I started my holistic practice, and I didn't know if anybody's going to even come. So I had 6 patients, and within a year, I had about 2,500 patients, and people were referring to each other, together, and they were sending patients my way with this philosophy. And I think that the children, my children, the work children, as well as my own children, I have 2, they have been the teachers, because every single person that came, because I don't have the type of practice that see you later, have a good life, I actually, even the ones that they no longer come here, a lot of them, I'm still in touch with them, send me their pictures. Let me see how their jaw is developing. Let me see what's happening, what's going on with the rest of their health. They continuously teach me in so many beautiful ways. So that's how the whole thing started.
It's such an amazing story, really, and quite fortuitous, really, the way you were led down that path, and to such a high level of specialized training as well, because obviously that takes a lot of level of devotion on your behalf, but then the passion to actually put the pieces together and see, that perhaps other professionals that aren't getting the level of training that you have and the level of knowledge that you've been given, perhaps they're not seeing things, and that there are actually problems out there that parents and children in society are experiencing that we're not, exactly, the healthcare system as a whole isn't equipped to address. So it's amazing that you've come to that. How would you describe, some of the shortfalls, or the the levels where we need to kind of evolve a little bit as, dentists and healthcare practitioners? What are we seeing in the what are parents going out into the world and going to their dentists, their orthodontists, and hearing that you think could maybe be improved, or is maybe something that we can work on?
Right. Well, number one thing that I think that you and I both agree with is, in medicine in general, we are more symptom based. We are more treating the symptom and not the cause. We don't look for the cause necessarily to see what was it that kind of made this dental arch this way. We don't ask that. We just go ahead and put braces and straighten the teeth. And we do that without necessarily even mindfulness toward there's an upper jaw and a lower jaw, and you're changing this upper jaw and lower jaw. But there's 20 other bones that they're all connected like a piece of puzzle to these two jaw, right? So when you're changing these 2 things, you're changing the entire cranium, and then that's connected to your neck and the whole spinal cord, and that's connected. I went through craniosacral cranial osteopathy training, significant cranial osteopathy training, and then I also met Dr. Nordstrom, and learned about the whole philosophy. But it was so fascinating to me that the entire time as an orthodontist, I was never really taught, like, hey, like if I'm changing these 2, I'm also changing the rest of the cranium. I'm also changing the neck. I'm also, or vice versa. Right now, if a kid's neck is out and there is some subluxations, or there is some torticollis in the neck, I don't do the tongue tie release, and I don't start my orthodontic journey until we start looking at with the osteopath or the craniosacral therapist to see where is it coming from, what is it doing, and then from that space, then I decide how to move forward. Because I just think that, like, oh yeah, there's a tongue tie, let's go and fix it. That's not how. It's not that simple. I mean, I know we want to make everything very categorical and cookie cutters, but it's not that simple. I have done probably 14,000 frenectomies, the past 14 years. And it's so interesting that every single one of these babies and children, and some of my moms and dads, they are so different, and one of them, like, after the upper frenectomy, her whole 1.5 inch difference between her leg completely corrected. Another person that was referred to me, she was, she was there was a dear colleague that just kind of insisted that I see, because I don't usually see adults anymore. I used to, but I don't see them anymore. I have plenty of kids to take care of.
You're too busy, I imagine. Yeah.
Yes, it's very busy. And it's also like there's a lot more general practitioners that they're doing this type of work, but there's not as much pediatric dentists that they're doing this work. And I would love for them to be more involved in this. But anyway, so I did the tongue release, and about 3.5 months later, the osteopath called me and said, it worked. I said, what worked? Oh, she got pregnant. I said, what is my tongue frenectomy has anything to do with her getting pregnant? She's like, oh, there was a tilted uterus that, because of the fascia, the way that it was so stuck, and some scar tissues, that basically I couldn't get it, and she just kept having miscarriages. And then once you release the tongue, I was actually able to work on the fascia and get the tilted uterus corrected. And then she was able to carry the child to full term. But these are the stories that I heard, and I took it in, and I try every night. I went home and I tried to make sense of it, and I tried to understand more and take additional classes in order to be able to understand it from a much deeper and scientific way. And at this, intuitively, it made sense. But in terms of the scientific ways, I still had a long way to go. I still have a long way to go, I think, because not everything is researched and understood. But these are the things that it kind of changed and shifted my thing to what I call integrative dentistry, or integrative pediatric dental medicine. And there's no such thing yet. I don't think that the term integrative dentistry is a well-known thing, although integrative medicine, it's a well-known thing. And that means you're looking at, first of all, the cause. Second of all, you're not just treating the symptom. Sometimes you might treat the symptom. Cavity is a symptom. Crowded teeth is a symptom. Mouth breathing is a symptom. But then you have to kind of look a little, back and get this whole picture about a person before you know what is the cause, and treat the cause either simultaneously or before even you can treat the symptom, in my opinion.
Yeah, I completely agree. And the observations that we're seeing, in the practice, what our patients are telling us, it very much lines up to this problem, is that there's an intuitive sense that there's something connected here, and we have not been taught in this way.
Yeah.
That the idea that the jawbones don't affect the cranium is crazy, isn't it? And the neck.
Yes.
And so it really is crazy. And to kind of have this intuitive feel, but then to put the pieces in place is very difficult. So you've really described that well, is that the scientific process to get this defined in a way that practitioners can roll this out in a clinical setting is difficult.
Yes.
So it's a big problem. Children are suffering this today. We have the levels of malocclusion in society is, I think it's one of the biggest problems on the planet at the moment for the human race. What are you seeing as some of the earliest symptoms? What are you most commonly seeing that kids are experiencing today in terms of what parents can see in the dental arch? What's your observation on the most obvious things that kids are experiencing?
So, you asked me that question in your email, and today I was treating one of the patients. That she's been. So there are 3 kids, and one of the kids has been with me since birth, and the other 2, they came a little bit after. They were a little bit more grown up. So they were more grown up when they made it to me. And I asked the mom. I said, what is it that you wish you knew before you met me? So all of these things that we talk about, what did you notice that was different, that would have made a difference for you to go and actually seek help? And her answer was very interesting. First of all, if a mom is very intuitive, she would know from the very, very beginning that there's something that is not right. And we start seeing things at infancy, right? Like, how many pediatricians do we know when the baby is not breastfeeding right, regurgitating, acid reflux, can't take the bottle, can't take the pacifier, hasn't pooped for 5 days. They say, you know what, don't worry about it. Half of the patients, they're like this. It's okay. Take some medicine and she or he will be fine. That's where the problem starts. If you look at so many infants, I don't know why, or at least the ones that they make it to my office, you already see the narrow and deep palate. You already see the maxilla that it's a little bit rotated down. You already see that the jaw is retruded. You already see that there is a little bit compression in the temporal bone, or there's a little bit of compression in the parietal bone. So it starts from literally the minute that the mom gives birth. Take a look, and some of the moms, it's their first birth. We had 2 new moms today, for example. But they knew, they just my pediatrician kept saying, no, but I just knew, this is not the way I'm supposed to be breastfeeding. This is not normal that I'm having this much pain. This is not normal that he's feeding this way and he's just kind of constantly having, regurgitation and a reflux and throwing up. So instead of just being okay with what my pediatrician said, I just kept going around and trying to find the answer. And sure enough, they kind of came to at my doorstep. And the kid has such a significant tongue tie that already at only 5 days old, he has a significant gag reflex. As you and I know, gag reflexes are not normal. You're supposed to put your finger all the way down past the uvula, past that little part that comes down, and then the gag reflex is supposed to come. Or a baby that it's kind of like this all the time, and it's just kind of crying and arching their backs. These are not normal stuff. There's something going on in a bigger picture of the baby. Babies that there were C-sections, babies that they were used forceps for, babies that they were, these babies, they all have, there's a little bit of a disharmony that it's happening, and it's easily correctable. That's the thing that breaks my heart, because if you start from the beginning, you can literally turn everything around, and then they can just go the right direction and nothing will come forward. But, no dis-ease is going to come forward. But if you don't catch it and you just keep ignoring it, or you're treating it with medicine, then the main problem is going to be hidden. The babies that they feed all through the night, babies that they cannot be laid back. As soon as mom puts them on their back, they start crying, and the whole night mom has to hold them. They have to hold them, upright in order for them to be comfortable. To me, a lot of these signs, they are signs of that there's something not working. And often there's the tongue, that there's either a tongue tie or some kind of dysregulation, or some kind of a cranial strain, torticollis, something that it just needs to be adjusted and moved into the right direction in order for that baby to have a very be more comfortable in their body. They did a study I don't know if it was ever published, but I remember in a lecture, they did a study that they found out babies with tongue tie, they use 48 additional muscles more than babies without a tongue tie. So these are the ones like that, they're just moving so much when they're eating, not necessarily like they're not just, comfortable, especially in the beginning. It takes so long for them to latch, or they start from the very beginning using the wrong muscles because of the bottle feeding, because as you know, like with the bottle feeding, you develop very, very different muscles than with the breastfeeding. So that's where it all starts in terms of the jaw development, because the the correct breastfeeding is the best jaw developer.
You've summarized it so well. I mean, there's so many things that you've just said there.
Yeah, sorry, I get too enthusiastic. That's one of my problems.
No, but you're absolutely right. But totally. But you've defined the problem so well. I feel the mothers out there are sensing these issues, and they're struggling to get the right, or the sense from their practitioners that maybe that their feelings are right. Look, there's a question here from Jacqueline. I'm just going to pop this up just because it fits our conversation a little bit. So because we've talked a little bit the connection between jaw bones and the growth of the cranium, how does a vaginal birth potentially improve a newborn skull? And what's your observations between cesarean sections and potential interventions?
So, I can't even talk about how amazing the vaginal birth is for the baby. So what happens is when they are going through the vaginal canal, there's a compression that happens in the skull as well as in the entire lungs, and everything else just gets compressed and then it gets opened up again. So when they're going through the canal, there's so much of almost like a remodeling of everything that happens, that not only gets the skull to kind of open up, but also to get the lungs to change from a fluid dynamic to the regular air and breathing. So they did a study, actually, this is not about the skull, but they did a study in Brazil, and they found out that the C-section babies, they had much higher rate of asthma than vaginal birth babies. So this is the vaginal birth from the gut bacteria that they get, from the microbiome that they absorb, when they're coming through the vaginal canal. Now they even have, I don't know if it's so LA or maybe in other places, but LA or New York. But I know that there's like, sometimes they take a little bit for C-section babies, they take a little bit of the feces of the mom and they actually cover the whole entire body of the baby in order for that microbiome to change and make sure that they have a healthy gut. But that's how amazing it is when they go through vaginal. But I also know that there are some babies that they get stuck for whatever reasons. They have moms that they have polyps, they have scar tissue down there, they have something that it's not happening, or the baby hasn't quite turned. I highly, highly, highly recommend that pregnant moms seek craniosacral or osteopathic training during their pregnancy, because it makes the biggest difference. If your baby very gently, not forcefully, but very gently, they can turn it around, put them in positions and all of those things with the fluid dynamic, especially biodynamic osteopathy. But if they're stuck in there and they're, especially when they get Pitocin and their cranium is banging against a bone, then there is like all kinds of other damages that could be done. So I think that there is if it's an easy birth or a relatively easy vaginal birth, then that's the best situation. But if there is an emergency C-section that needs to be done, then I highly recommend that you see your craniosacral therapist and osteopath right away, because it makes a huge difference. For some of these babies, there is a baby ALF, infant ALF that we make, the ones that they have a really, really compacted head, and
right.
Yeah. So I put, it's like the cutest, most adorable thing because it's like this big, and so, but taking an impression is a whole, thank God for my training, taking impression with cleft palate patients, but I actually, in some patients, I make a baby out because my intention is actually to avoid all of those things, braces and all those crazy things later on, at the later on, and form their cranium and their whole body in a way that it's optimal, and it goes, and it moves to the right direction. So
So just to clarify, because that's a really interesting treatment modality. You, in some newborns that have a very narrow palate, and you're noticing these symptoms, perhaps painful feeding, you use devices to expand the palate in very young children.
Yeah, that's not my first thing. So we do we do the body work. We do a little bit of it's a little bit more complex because some of these patients, because I want to be also clear, some of these patients, when they don't have the suckling in place, because as you know, suckling is a huge thing in terms of the primary reflex. So if they don't have the suckling in place, then everything else is off, and you have to make sure that you first establish the suckling, where like as soon as you put your finger in the mouth, like the baby starts to suckle and not bite, actually like the tongue kind of moves this way. So we start usually with the upper and lower frenectomy if it's needed, and then after that, if it doesn't quite open everything up and we're not quite seeing, because in infants it's miraculous. Like I do the upper frenectomy, which opens everything up. The midface just completely opens up. It's underrated how much of a difference it makes in developing the sinuses and this whole aspects all the way to here in babies. And then right afterward, like their faces, like their parents, like, oh my God, the face changed so much, like the eyes that they're like this, it starts coming up. And after that, we do the lower frenectomy, and then, but literally within a week, the whole palate expands. Once the tongue has an ability to function properly, it expands. But in some babies, when they were sitting in utero in a way that it really impacted the cranium, maybe they were twins, or they were against something, or mom has a little bit of a twist in her uterus and sacrum, all of those things, like then you see that, and the palate is really high, they can't even get to the top of the palate to do this beautiful movement of the tongue, which starts so many things. Sometimes they call me poop whisperer, because as soon as I put my yummy like gloves, like in the mouth, and they start getting the suckling going, like all of a sudden they poop, and they're like, why is my baby poop as soon as they start feeding, because it was one tube that went to different direction, right? So it actually initiates the tongue movement, initiates the peristalsis of the rest of the gut and intestinal tract. But literally you see like within a week changes. If it doesn't, then I do put a small device that starts, by them biting on it, then they start actually developing the palate and lowering down the roof of the mouth, as well as developing the sinuses.
Yeah, that's amazing, and the multifaceted inputs into the oral ties. Really interesting what you say about the connection of lip ties. For those that were listening, what Dr. Sami was saying is the lower tie is the tongue tie, so the tie under the tongue, but then the upper tie is the labial tie, or the lip ties. And what you're describing there is that there is a tension that goes right through the skull sometimes, held by these ties.
Often.
I mean, I've noticed that because I had mine released and I had some reattachment. I'm going to go for a personal release because I feel there's some tension in my face here. But so you're describing, so our eyes that are downturned. What are some other symptoms of this tension?
Well, the first thing, like, just look at your baby's lip, right? And you can see in babies so much more than when they are older, because then when they get older, then there's other things that kind of comes up and it dominates, so you might not be able to see it as clearly with an untrained eyes. But like in babies, for example, their nose is kind of like pulled down a little bit. It's like there's a little bit of tension that you see, like right at the tip of where the nose and the upper lip they meet. Their lips is very like tucked in sometimes. All of the ones that they look like they're frowny babies, like they say, that was my daughter. Everybody's like, oh my God, she looks so grumpy. And I'm like, she has her upper lip tie that I need to release. I haven't released yet. She was always like that, so, well, the first 6 days of her life, but until I released that upper tie. But it's just because there's tension, and this hasn't opened up completely because of the upper lip tie. It just, it doesn't quite create that. In adults, like what I do in some of I only do my moms and dads on the most part. So if they ask me, but I asked for their baby pictures, and I asked for all of their baby history. And a lot of them, with the upper tie, they had allergies, constant sinus infection. This midface didn't quite open up. This midface couldn't be quite developed. And I think that we are not giving enough. I know there's so much talk about tongue ties now, but I personally don't think we give enough credit about the upper tie. And I know so many practitioners that they release the tongue tie, and then the patient, like 3 months later, they come to me and they say, oh, they didn't think that this was necessarily done. And it's like literally like the tissue goes underneath and hooks underneath and pulls the whole thing up. And you'll see the tension kind of manifest in different ways. Some babies, even at the baby thing, they have like a gummy smile. Like that's all they show. It's like gum. Some of them, you can't even lift the tongue up. I mean, the lip up, it's so tight that it's just basically like this. And those are the kids that they get a lot more cavity, because the lip is constantly sitting on top of those teeth. I have seen that every single patient, that they have these 4 teeth cavitated almost. When their lip was tight, they significant effect on their cavity rate. So there is a lot of, and then you can, as an adult, you can actually like feel it. Like when you lift up your lip, do you feel a tension or no? It just kind of, you lift it up and it doesn't feel anything. I did my lip tie release actually. And it's a funny story. I think Dr. Zoggy. He was in my clinic, and we were doing this lower labial, because we were kind of experimenting to see what does it make a difference in kids that their lower jaw doesn't come forward. And there was a kid that was really young, and he didn't cooperate. So we had this 1 hour, and I said, release my upper lip. He's like, you don't need it. I said, I want to just feel how it is. And I think I need it, because whenever I go to my osteopath and he's working inside my mouth, I just feel all of these things. It was so interesting. First of all, I wanted to see how all these patients that I worked on, how do they feel afterward, but just wanted to also experience it myself. The minute that he started like releasing it, it was almost like I'm breathing well for the first time. And you have to understand that this is my work, so breathing, airways, all of those things. So I thought I have a pretty big airway, so it looks really good, so I'm breathing well, but I always had to put like the nose strips at night and tape my mouth at nighttime. And it was incredible how much of a difference it made right from the time that he started cutting and releasing. And I told them, I said, if there's tension, go ahead and kind of, release the tension. And my craniosacral therapist was there, and she was guiding him, because we do the releases with osteopathy and craniosacral. And everybody, like 3 weeks, I think about 3-4 weeks later, all my patients are going, oh, Dr. Sami, you're sleeping better. I think you look so much younger. Did you do it with your face? I'm like, yeah, I did like a frenectomy on myself finally. But it made such a difference. And I only did this. I think I'm going to go do this afterward. But I only did this one, and it was really an interesting experience. How much of a difference, even as an adult, it made to my face and it made to my breathing. I don't have to put the tape anymore at nighttime. My mouth doesn't open anymore.
Yeah, you've just inspired me. Actually, I'm going to have to reinvestigate because Dr. Zagi released my tongue,
Yeah.
and that was the second release. Yeah, but I think I have to go back for the labial ties.
Yes.
It's such a deep topic. You describe so well the interconnected. It makes so much sense. We're starting to talk about lip seal and breathing, and how these things are all interconnected, and that how parents can pick this up early. There's a question here from Melody that kind of leads us into a little bit away from the newborn space. We could talk about this for the whole hour, but she says, my 1-year-old son often sticks his tongue out and is done from the beginning. He has a little lip tie. Could that be why? Why do you see some kids sticking their tongue out for some reason or having these tongue thrust habits?
Oh my God, so many different things. So I would start with quite often what I see is C1 and C2 is kind of congested like that, and it's compacted. So then when you go in there, basically like they have that need to stick their tongue out in order to release that C1, C2. That's one most common thing that I see. If they have an upper tie, it's also kind of creates this tension in the back, and then that can also cause the tongue to stick out. And this is like, kids, they explore with their mouth all the time, like everything that they see, they put it in their mouth first to experience what the world is. So this is like more of like constant tongue thrust, or the kids, I have babies that they came and like their tongue was constantly sticking out. Babies, they should have a nice lip seal. They don't even know how to mouth breathe until something happens, and they basically they kind of build up the habit. But babies, if you actually kind of close their nose, they get so distressed and they can turn blue, and then they figure out, oh, there's another hole to breathe through. But so that's but when you're actually kind of like looking at this part, the tension of the upper lip, it can also do that with the tongue. And sometimes it's the posterior tongue tie. I think most of the practitioners are very, very savvy at knowing like if there's like a tongue tie right at the tip of the tongue, but often they don't really know how to diagnose the posterior tongue tie. When you go with the posterior tongue tie, when you ask the kid to lift up their tongue, their tongue either curls, or when they cry, if they're like tiny babies, when they cry, you actually see that their tongue kind of hangs in the bottom rather than just kind of all the way lift up to the top of the roof of their mouth. So that's one of, and then also the gagging reflex sometimes comes with the posterior tongue tie. Sometimes the constipation comes with the posterior tongue tie. Airway issues starts with the posterior tongue tie. So there's a lot of things that a lot of kids that I see that their front of the tongue gets diagnosed, and then with all the respect to everyone, but I see so many practitioners that they just scissor the front of the mouth, and they might take care of breastfeeding momentarily, but they don't necessarily take care of the developments of the head and neck and the entire face. Because if we have a saying that I said, behind every anterior tongue tie there's a posterior tongue tie. It's one tissue that goes all the way back. So if it didn't open up, didn't just open up in the front, it didn't open up in the back as well. So you have to open the whole entire thing up in order for the tongue to be fully functional, because the function of the tongue does so many things, as some of your post indicates. I think you had a post today. I was just like in between patients, I was looking at Instagram, and I think you had a post today about the function of the tongue and what it does for the creations of the palate and so much more. I think parasympathetic and sympathetic nervous system and brain development.
Oh, we've just lost Dr. Sami there for a second. But so what Dr. Sami was talking about there was the levels of the tongue ties. So an anterior tie, which will go to the tip, and then a posterior tie, which will run back into under the tongue. And she's saying that often kids can be diagnosed with the anterior tie and have that release, but then the problems can connect to having a posterior tie. And you can have reattachment after releases as well. We'll just wait now for Dr. Sami to reconnect. If anyone else has any other questions, we're going to post some more questions towards the end of the interview. And we're also going to run through the orthodontic interface as we move into older age groups and how we help develop the jaw in kids. And so one of the big factors that I see in the clinic is that oral habits that affect the growth and development of the jaw. Thumb sucking is a big one. So kids that thumb suck will often present with jaws that are slightly misaligned, and they'll sometimes have an open bite. And so what happens then is that if we have an open bite, you can develop this tongue thrust swallow. So thumb sucking is often a sleep habit, and it's often to do with a child trying to find parasympathetic rest. Dr. Sami was talking about how the tongue directs parasympathetic rest, and she describes so well how this is connected to the entire craniofacial system. But so in early childhood, if a child develops a thumb sucking habit, it can affect the growth and development of the jaw, the bite of the child, and then later on the swallowing habit, which then affects the development of the upper jaw. And she was just starting to talk about then the back of the tongue, which is really important. I put up a post today about how the back of the tongue must lift up and seal the oropharyngeal space. And this is something we talked to Dr. Sandra Khan about a month ago, who is an orthodontist and is talking about getting the back of the tongue. And this is something that I find that I have to really teach patients when you're using your tongue. You really have to work. You learn the spot, which is for the tip of the tongue, which is behind the upper front teeth. But then the back of the tongue is for where, if you can see my palm here, where the palm seals up to the roof and back into the oropharyngeal cavity. So when you're swallowing, you should actually feel a very deep suction mode, and it makes a noise. And you can actually do an exercise where you straighten the spine right out against the back. And I'm going to make some videos on these to help people kind of visualize it, because I know these exercises are hard. It's difficult to explain to patients, and you have to strengthen the muscles. And as Dr. Sami describes so well, it goes back to early developmental factors. When we were growing and developing as newborns, if we had a tie, which a lot of kids do now, then it affects the growth and development and how we use the tongue. So I'm just going to send a quick message to Dr. Sami to see if she's rejoining, and then we'll. So, okay, so Dr. Sami is rejoining. Okay, so as we move forward in the conversation, as you can see, her dual speciality has helped her to see that growth and development of the entire dental arch is completely, we can intervene in this, and it's about very clever diagnosis, which Dr. Sami is probably one of the best in the world at, to be honest. She's looked at so many different modalities, the osteopathy, that these things, we can correct the muscle habits that then begin to help to grow the jaw. And the breathing, we talked about the upper lip, how the upper lip creates tension through the front of the face, the skull, and how you can pick that up in newborns with drooping eyes and a frowny face in a newborn, which is really interesting, and how you can pick that up in the lips. So if Dr. Sami should be joining soon, but if you have any more questions, please post them in the in the comment section, because you really, she is quite a rarity. You don't get the opportunity to talk to specialists like this. She's based in California, and the model of functional dentistry that she's practicing is really, what I hope to be, the future. If we can clone her, that would be great. But so for kids that are growing and developing and that have had these issues, then we start to see them in the dental chair. Parents can start to think about, how did a birthing, the modality of births, whether it was a natural birth with the complications or a cesarean section, how does this affect the breathing of of the child? And then how does this affect the teeth? And you can see it. The first thing I look at when a child walks in the door is their shoulder posture, and so whether the shoulders are postured back, and where the neck and the head sits in relation to the shoulder, the spinal posture. Does the child sit lean forward, and when they sit down, do they have a forward head posture, and is their mouth posture open? So all of these things, you can pick up quite simply, and it really does. You can then see it in the mouth. So these things will affect the orthodontic development of the child, and that, as Dr. Sami says, we can begin to intervene in these processes via simple devices to help expand the palate where children are not able to to correct completely themselves. Because when we have issues with ties that have been there for a long time, it creates a habit. And if you saw the post this morning on the tongue and the tongue posture, it really is a very difficult thing as an adult to correct, and it takes time. It's like an exercise practice. And it takes exercise. So it often takes, in our clinic, we go through exercises, and with kids especially, we introduce them to how to move the tongue and how to connect this to breathing and closed lips posture and walking, and how these things all affect their dental development. Okay, so I'm just going to okay. So one of the big signs of a tongue thrust swallow was an exercise that I posted this morning, and it's what you can actually do is test whether you use the tongue, a tongue thrust swallow or a tongue up swallow. And so it's an exercise where you hold your lips away from your teeth, and then take a small drink of water, and then place the tongue and use the tongue to swallow against the palate. And so I'll just demonstrate it here while we're waiting for Dr. Sami to see if she can reconnect. But so what happens is that you hold the lips apart, and then what I'm going to do is swallow as and use my tongue only. So what we're trying to do is disconnect the lips from the swallowing response, and then use the tongue only to control any liquid in the mouth. So we shouldn't see any liquid moving forward. And obviously, I don't have any water here with me. But so if you try it with a very small amount of water, you should use the tongue to balance the water and move it to the top of the mouth, seal it, and then push it to the back of the throat. So the movement looks a little bit like this. And so what I had to do then is that when you don't have the lips to help you to create the seal, it actually means that your tongue's doing all the work. And so you'll have to use the back muscles of the tongue. This is what Dr. Sami is talking about when she's talking about posterior ties and how it affects the swallowing of a child, and how the palatal growth of a child will be affected as a result. Okay, so we'll just see how we're going here. Okay, so we'll just run through and just see if we can pull up a question while we're waiting. Okay. So how do you train a 15-month-old's tongue to rest on the roof of the mouth while sleeping? I'm struggling with that aside from diffuser and gently trying to close the mouth when I catch it. How do we know the tongue is in the proper position? Yes. So this is a difficult, a difficult thing for parents to broach, because newborns they're very hard to get into the mouth, and as Dr. Sami was describing, there's often misdiagnosed or undiagnosed potentially oral tethers, but also too is that sometimes the children, they create a habit of this tongue thrust, and we don't get the proper sealing of the roof of the tongue to the roof of the mouth. And so using a diffuser is a good approach because it can help clear the sinuses. But so what you can do is to begin to, I personally find, and with my own kids, is that tongue clicks is the babies watch their parents' mouth very closely. So showing the baby's tongue clicks, it was an effective way for me to, I've got a 2-year-old and a 6-month-old, to help them start to visualize that the tongue goes to the roof of the mouth. And so the way we do it is just and what you really want to focus on there is keeping the seal while opening the mouth. And so if you do that to a baby, you'll actually see that their eyes will follow you quite distinctly. And what you can also do is with your finger, you can stimulate the palate to help the response to the roof of the mouth. And so there are a few, there are certainly difficulties in teaching kids to seal the tongue to the roof of the mouth. But overall, it's something certainly to focus on, and it's a journey as well. It looks like Dr. Sami is back.
I'm so sorry.
That's okay, no problem.
The craziness of the computer world.
Oh yeah,
and I'm
right.
Just learning.
Okay, so we were talking a little. We were starting to go into older age pediatric age groups and signs where of how kids that potentially haven't been diagnosed, of all the amazing things you talk about with newborns. How do we, what are the signs that parents start to see? And what, a very common thing I see in my clinic and the parents will notice in kids is thumb sucking. What are the signs, and, what are some of the things and age groups, especially, that we should be thinking about, addressing these issues?
So what are the signs? Well, it's as I said, the breastfeeding is a big sign. Sometimes it's not necessarily lack of breastfeeding, because if a mom has a lot of milk, the baby they're very, very intelligent human being. And many babies, they find their way using their mom as almost like a bottle. So they start suckling the milk as if like they're suckling on the bottle. And the bottle feeding is a very different mechanism than the breastfeeding, because they're usually in the bottle feeding, you using the mentalis muscle and the masseter muscle. And in the breastfeeding, you can actually see the pads, in the buccinator growing. So it's a very different mechanisms and the developments of the face that actually occurs. So it's not necessarily painful breastfeeding, but it's the breastfeeding that it's like 24/7, breastfeeding that the kid's having all of those issues that I said. The next thing is probably, little signs like the kid cannot take a pacifier, or it cannot, or it never bottles feeds, so it would never take a bottle. Sometimes those are some of the subtle, yet, profound. And then we talked about the regurgitations, constipation, all of those things. Later on, it becomes about grinding. It's about not sleeping through the night, when they're supposed to be. Usually around a year old, you should expect your child to have a comfortable 7 hours of sleeping, and not necessarily waking up for any breastfeeding, not necessarily waking up unless it has become a habit, and even earlier, often like by 5-6 months, they can sleep for a longer amount of time. But waking up is a big sign that something is not. And often what I see is that the parents, they just kind of have a child to be sleep trained, so they kind of take them to another room, and then the child just kind of falls asleep, and they bring a sleep trainer, at least in LA, they bring them and to train them. Not to say that that's not the right thing to do, but if they do have airway issues and they do have some something that is putting them in that fight and flight, and it's activating the sympathetic nervous system, such as the retained primary reflexes and a few other things, then you're basically kind of masking again the symptom, and you're forcing the child to kind of sleep by themselves and cry it out or whatever that it is. But you haven't really looked at the main issue. You have missed the main issue until much later, until the 3 and 4-year-old, that it's like all night long. I just had a new patient, 7-year-old, and I asked, so when did he start sleeping through the night? And both mom and dad looked at each other like, he still doesn't sleep through the night, so like usually around 1-2 o'clock, he starts kind of wandering to our bed, and he wakes up a lot, snoring, pickiness in food. I think that's a really important aspects of looking at what's happening. Kids that they choke on solid foods, they don't necessarily, they have to have puree. It's actually the baby-led weaning tells parents to start teaching your kids, even like before all of the teeth come in. Rudolf Steiner, actually, I don't know how much you have studied Rudolf Steiner, but my husband and I, we went through anthroposophical training. So, and he's so brilliant with like when to introduce food and solids based on what teeth comes in, so like, these are the incisors, all the things that you incise. And then as you kind of grow the molars, it's like the meat and everything else gets introduced. Just really beautifully, he kind of brought all of those things in terms of feeding and teeth forward. But those are some of the things that I see most often. Kids that they have a bedwetting still going on after 3-4 years old. Children that they are, and then what happens again, instead of seeing that as a sign, it's embarrassing. They shame, and they said, oh, you're a big boy and you're not supposed to be wetting your bed anymore. I don't think they're doing it purposely. There's something that it's not quite there, and that's what's happening. Children that they get up and to go pee in the middle of the night, every single night, not just one random day that they had too much liquids, but every single night. Mouth breathing is a big thing. I can't tell you how many parents I've had that are like, oh, he does this really cute snore. There's nothing cute about it later on. So, I mean, it's cute when they're babies, but it's definitely a sign of airway obstructions. And then you start seeing it a little bit later when they start walking. I look at the balance of the body, the right side, the left side. I actually, as soon as they start walking, don't miss the crawling, because the crawling part of it, so many parents, they come and they proudly say like, oh, my child never crawled. They just went upright and they started walking. Oh my God, the beauty and the magnificent of what happens during those crawling period, proper crawling, not the army crawling, not so much brain development, so much jaw development. The other thing that it's very interesting is when you start looking at, so I took a facial development osteopathy course, and there was an amazing aspects of, what happens with when you need to take the pacifier and the bottle and the, I don't like the sippy cups anyways, but if there was sippy cups, so our teacher, who's a really great friend of mine now, but he was talking about how the tongue and the teeth, they basically they start changing the development of the cranium. So in the beginning, when there's no teeth, the tongue kind of comes almost out, and it develops the cranium more front and back, anterior, posteriorly. Then it starts basically kind of developing it on the transverse point. But once the molars, they start touching in and they start coming together, that's the time for the tongue to start developing everything vertically. And what happens when vertically or up and down it happens? The airway develops. So kids that they're tongue thrusters because of several things, wrong breastfeeding, bottle feeding, pacifier, although I am a proponent of right pacifiers, but for a shorter amount of time. But pacifier for elongated amount of time and wrong pacifiers, then they don't have that vertical growth. And because of that, then they start, or thumb sucking also does the same thing. Then they start actually having airway issues and the lower jaw falls behind.
What amount of time do you advocate a pacifier and a certain type of pacifier?
So that's the same exact thing so I tell my parents each child is significantly different, right? It's very unique. Some kids, they come in at 4 months that they have their first tooth, and some kids, they are a year and 2 months and they still haven't teeth yet, right? So I tell the parents, go in there and take a look at the first molar, baby molars, and when the first and second baby molars, they touch, you need to take bottle out, pacifier out. Thumb should never go there, because it's always too small for that cute little palate anyways. Thumb sucking should never happen, or finger sucking should never happen. But and then also, like, there has to be proper water drinking, from a proper cup, not those sippy cups that they actually promote the thumb sucking. So that, the tongue thrusting. So yeah, I think that just go inside your child's mouth. Even like I actually say that breastfeeding, that should be stopped by that time. So, but it's very different. I can't tell you at 1.5 years old, because somebody might not have their molars until 2.5, until 3 years old. But usually when the molars come together, it's the time that the tongue needs to develop the whole cranium vertically, and they should be able to kind of look at that and determine that things they should be kind of coming to an end.
Yeah, that's a great diagnostic tool, and I think very few people know that.
No, that was amazing for me to also learn, because I was like part of so many breastfeeding groups, and I breastfed my children, and nobody really has, like, they have an age, and I don't think it's necessarily an age, because each child is different. And then looking at the whole growth and development of the cranium, and when it happens, is very determined on the teeth. When the teeth come in, that's when the development of the cranium happen. And that's why kids that they don't have properly developing kid because of certain craniofacial anomalies, they don't necessarily have a cranium that opens up also fully and properly.
Yeah, it makes complete sense, doesn't it? And even the order of the eruptions and the difference in each kids as well. Okay, so look, we've talked a lot about the preventative interface. You're a wealth of knowledge in this area. A lot of parents out there are just kind of switching on to this stuff. There's a lot of mindful parents out there that realize that there's a lot that we're learning, and we've learned, and that you've put such an area of expertise together. What are some of the issues? Let's look at the age group between 4 to 7 in the pediatric dentition. Orthodontically, that parents, because this is it's not very well known out there that we can intervene potentially orthodontically. And what are some of the signs? And there's a question here from Jessica that brings up about cross bites. So what are some of the signs, and what are some of the interventions that parents can be thinking about, or at least be aware of in the pediatric dentition? Okay.
How are crossbites corrected? Again, I go back to look at why the crossbite was created, right? Is there a deficiency that it's happening? Is there a strain on one side of the face that basically started the crossbite? even prior to the teeth coming in. And then because that side of the face didn't develop, it created that crossbite? Was it that there was a trauma to that side of the face that just kind of stopped the growth and development of, upper jaw or the lower jaw, maxilla or mandible? So I look at first the cause of it, because that's going to determine what I'm going to do first, second, third, all of that stuff. The other part of it is, if the crossbites, they have to be corrected, because if you don't correct the crossbite, you're actually creating now the deficiency in one side of the face. You're completely creating an asymmetry in the entire face. Crossbites are not about teeth. It goes all the way to the eye, to the ear, to the whole entire development of that side of the face that the crossbite is. And once it gets locked in, then it really doesn't move anymore and doesn't allow that side of the face to fully develop. So looking at your teeth, look inside your kid's mouth and just take a look. Take a look if all the front, all the upper teeth are on top of the lower teeth. Look to see if their baby teeth, they have spacing in them. Because so many parents, they come in and it's like, oh, my child has perfect looking teeth and everything is like right next to each other. I'm like, yeah, for just a couple of more years, and then those permanent teeth that they're 3 times as big as their baby teeth come in. And I don't know, I haven't seen any of them that they kind of grow into their bigger teeth yet, but maybe there are some forces that changes. But most of the kids that they have perfect looking teeth right next to each other, there's no space between them, they're going to have crowding. Start now. Don't wait for the permanent teeth. I never wait for the permanent teeth to come in. I look at what's happening, what's the emotional capacity of the child, because I have started as early as a 2-year-old, an infant even. We talked about it, but even 2.5-year-old to have an appliance in there. Or like if they had significant airway issues, I do nothing. I just send them I have a breathing re-educator and a myofunctional therapist that actually start working with them just to kind of develop that tongue and airways and start treating that. And then after that, if they need it, I put an appliance in there, but never in the beginning or, right away. When you see that your child is breathing through their mouth at nighttime, for sure they're going to have issues with their teeth. They tend to have more cavities. They tend to have more issues with like grinding in the middle of the night, posture, like they start like basically bringing their shoulders forward because they're kind of sticking their head out just ever so slightly in order to open up their airway. So they engage their shoulder and then they start having a little tiny hump in the back. A lot of times also airway, when I see airway issues, like I also see that the hip is rotated this way and then the feet are kind of, coming, pronating in. So take a look at the whole child, how are they walking? How are they speaking? Like if there's speech issues, for sure there's stuff going on. And don't just go to a speech person to resolve it, because the speech person might know only about the tongue movement. Some of them, they don't even know about the tongue tie and lip tie, unfortunately. Just kind of go to someone who understands the whole picture and start like looking at the whole picture with the speech issues, because it might not be just the fact that they can't get their tongue up. And then you might, just kind of take a look at things and miss the bigger picture of what's the underlying problem. But these are some of the things that the grinding, everybody thinks is stress. I don't believe in children it's stress. I actually think that there's a few other things. One of the things that it's never talked about, it's metabolism of sugar. Kids with the metabolic issues and sugar metabolic issues that has kind of come from mom during pregnancy. And that's a whole different topic. They start basically their sugar level drops significantly down. And this is like the fastest way that they can get their their blood pressure and heart rate up. So the trigeminal comes in, starts getting activated in order to do that, and then that's what happens. That's one of the things. But there's several things for the grinding, but that's one of the things that it's not often talked about or looked at as a dental practitioner. So so some of these things are really important to take a look at, because they will have significant outlook in later. So just giving a mouth guard, it's again just treating the symptom. It's just putting a band-aid. It's not necessarily taking care of the issue. You look at why the person is grinding, what's happening in their body that it's activating. Because when you put a mouth guard without really understanding what's happening, they're going to grind even more, and then it's not going to necessarily have the effect that you want to have.
Absolutely. And yeah, the multifaceted issues that you're describing, there's so many inputs here, and the way the jaws are listening, it's just, it's crazy that we've thought about it in such a mechanical way, isn't it?
Yeah.
Look, we're running out of time. There's so much we can talk about, Dr. Sami.
I know. It's an interesting topic. So at least we are both so passionate about it, and you wrote a whole book about it. So
well, you describe it in such, the modalities that you've gone through, you've really put all the pieces together, because a lot of people that are listening, that they're probably going to say that, my dentist or my doctors, they're not going to talk about this way. And I think that we definitely kind of have to put into perspective that there is definitely a learning period happening in the healthcare industry happening right now. And and parents, it is a little bit on parents to kind of go out there and find the pieces. If they don't have a Dr. Sami near them, if they're not in California, then it is a little bit, you have to kind of put the pieces together, right? How would you suggest, parents that are going, with children, say between 7 and 12, that are, being told to wait for orthodontics, and how would you suggest that they go about this, and and things to look out for?
I hope I don't piss off any of my orthodontist friends, but and I love you guys all, but I completely disagree with that. I think that teeth has nothing to do with development of the cranial with the cranial development, permanent teeth. So you don't wait for permanent teeth to come before you treat the mouth. Because then all you're doing is just tipping teeth, and you're not necessarily treating the whole body. So that whole 7 to 12 years old, when you go to an orthodontist and they say, wait, don't worry about it, we'll take care of it later, I don't believe in it. I believe, let's look at the cause, let's see what's happening, and if there is a problem, we want to solve it now, one way or another. So look for somebody else if this resonates. Some people, they just want to go and treat the teeth, and they just want to have straight teeth, and bless your heart, and this is not the conversation that you want to have. That's a great thing. Go and find the orthodontist that does that. But if you have a mindset, which I call, more conscious parenting, where you're looking at the entire picture for your child, I would say that as soon as you see a problem, find someone that can help you. What I think the blessing of COVID that has happened, it has really, really made so many practitioners accessible to us, because before I couldn't come to you, and because oh my God, when am I going to go to Australia? Now I can just call you and make a Zoom appointment, and then just kind of send you some picture, and at least you can tell me what your thoughts are. You might not be able to treat me, but you can at least tell me what your thoughts are, and you can at least give me a different perspective or recommend a few books that I can read. So I think that the whole world, with this whole Zooming aspects and this telehealth and telemedicine, has become so much smaller and so much more accessible. So I would say, if something in your gut feeling doesn't feel right, don't do it. Like, go find a practitioner that it more resonates with your philosophy of living. This is I wish you could have come to my practice. Like, this is the philosophy of my living. All the walls in my clinics, they're toxic free. All the floors, we have a garden that's a completely biodynamic organic garden, with like fruit trees and all of those things. This is the way that I live. So I bring how I live into my work, and then I look at everything in life as a connected way of, in all levels, physical, emotional, mental, and spiritual. So find that. And then the other part of it is, I have a warning because this has been an interesting topic because of my own super laxity of the joints. Like, when you put braces on patients that they have hyperlaxity in their joints, that means their joints are super stretchy. Like, if you look at, I don't know if you can see it, but I have a lot of laxity in my joints. So when you put braces on that, you completely mess up their jaw, because you're forcing and pushing everything, into a certain position. And the teeth, they might look brilliant, but not necessarily the jaw joints, the neck, you're creating a lot more issues. So if your child has, and you can see it, like the legs, the way that they stand is not straight, it kind of bowed out, you can see how like they can do all kinds of crazy gymnastic things, that nobody else can do. If your child has a hyperlaxity in their joints, like, going through like regular braces is a completely wrong way to go through them. You need to like look for alternative stuff. And you need to look to see what you can do. If your child has other issues in their back and neck, such as torticollis, scoliosis, braces can make you so much worse, because you have to, when I'm looking at what to do with each side and how I'm expanding, I'm matching it with how the scoliosis is in the spine. Because if I don't do that, I make the scoliosis so much worse. Instead, I have to kind of like do it in a way that like the spine is actually more corrected rather than getting worse. So all of these things, they're like little intricacies that you have to pay attention to, that I wasn't, I don't know, maybe some orthodontists, they're so much more astute, but I wasn't taught to look this way in school, and I don't think a lot of us are trained. And I think we're going that way. We're looking at airways so much more. We're looking at, things like how does sleep, and tongue ties and all of those things. But I think that maybe in 10 years, I think we'll be there, but we're still not there. The majority of people are still just looking at teeth and straighten the teeth. And sometimes I've seen so many cases that there's straight teeth on a completely, like, the face that doesn't even, the arch doesn't even match the neck. It's like almost like on the side of the neck, and the patient constantly has neck issues and back issues and everything, because there's literally their arches, they don't sit right in their mouth. So even though they have perfectly straight teeth. So look to see, to first of all, understand, and then be your child's best advocate. It's no longer okay to just like, oh, well, I went to this person and they just said this and I just went with it. If there's something inside, I always tell my moms, you have the most intuition to listen to yourself and know that there's something in you, because the cells that from your baby that traveled all the way through, during pregnancy to your brain, there was some research about that it acts like a Wi-Fi. Like what's best for your child, and it in your gut. You don't know how to put it in words, but it in your gut when there's something that it's not resonating. So if I'm telling you something, even though if it's not out of fear that you're rejecting it, but if out of love, don't even listen to me. Like, basically go with your gut. But again, it's like the fear versus love, because some parents, they also like, project their own fears into their child. Like, oh, I had a really bad childhood experience with the dentist, so I'm not going to take my kid to the dentist. Oh, I had a very bad childhood trauma with braces, so I'm not going to do this. So not from fear, but if it's from love and you like from that intuition and that deep space of connection with your child, go with your intuition and don't listen to anything else. That's my advice to my patients.
Yeah, I try to explain that to you. You explain it so well. Is that, I always try and say to patients, go with your gut feeling on that, because, underneath there is something that knows what you need. And, if you feel something that's off, then, you go with that.
There's
You can't quite
wisdom.
explain it, right?
Yeah.
Dr. Sami, you're an absolute enlightened being. It's been an absolute pleasure. I love that you have for those that can't see, but there's the human skull and the Buddha sitting next to each other on your shelf. It sums up so well, right? What the whole conversation.
Exactly.
But look, I'd love to. We're going to have to continue this, because there's so much more of, we have to crack that whole head open of yours. You've got so much knowledge in there. It's really important. Thank you so much for all the work you've done. Where can people find you and learn more about you?
Well, my Instagram is Dr. Sherri Sami, DrSherry Sami. And I also have a Facebook that I'm beginning to get busy. It's called Conscious Chit Chat with Dr. Sami on Facebook. And then I'm about to start some podcasts too. So we'll have you on the podcast pretty soon, hopefully, and we'll continue the conversation. But definitely 2020, was a year that I felt like I start to, to do more teaching, because up to now, like with my own younger children and practice, I've been so busy, I haven't been able to do as much. And this is a huge calling, because the more of us that we know, then the more that it can be of service to so many people from the beginning. And then we don't necessarily face a lot of stuff later on in all dimensions, not just the mouth, but like that's just the beginning to the rest of your health, including the lungs health and the gut health and everything else. So those are some of the things that they can look up. And if they had any questions, Instagram is definitely a great place to ask me those questions. Send me a private message, or you can also email me at drsherrysami@gmail.com, DrSherrysami@gmail.com.
Dr. Sami, thank you so much. I can say with absolute sincerity that the world would be a better place if there were more Dr. Sherri Samis out there.
Thank you so much. That's so the same thing. I can say the same exact thing about you. Thank you so much for all the work that you're doing and for all the beautiful posts. Each one of them, they can be a separate book by themselves. So I really appreciate them.
I mean, you're a perfect example of how much knowledge there is and that needs to get out too. So,
yes.
We're going to work hard to get this out there. And, thank you again for everything that you've done.
Absolutely.
All right.
Thank you.
Thank you guys for joining us.
Much life.
Bye-bye.
Bye-bye.